Hi guys, welcome back to the channel. Today we are discussing the landmark trial. This is also NMJ English General Medicine published trial. EOLIA, Extracorporeal membrane oxygenation for a severe acute respiratory distress syndrome. My name is Dr. Buddhabhushan Borade. You can follow me on Instagram, MediTalk by Dr. Bhushan. You can follow or subscribe to my channel, MediTalk by Dr. Bhushan, to further get a new video.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accept no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
In a patient with a severe ARDS, does the early initiation of extracorporeal membrane oxygenation compared to standard care improve the mortality at 60 days? Background for this study: the severe ARDS continues to have very high mortality despite the improvement in mechanical ventilation or rescue therapies. We know venous ECMO provides oxygenation and carbon dioxide removal and may enable to improve lung rest and reduce the ventilator-induced lung injury. However, ECMO is highly invasive complex procedure which may result in a significant complication. The CISA trial, Lancet trial 2009, showed that the referral to the ECMO center for the consideration of ECMO improved outcomes, but my patient did not receive any ECMO and treatments in control arm were not standardized. Thus, remain unclear if ECMO improves the outcomes compared to standard treatment, including the protective lung ventilation, proning recruitment maneuvers. In further study, we can compare the CISA trial versus ECMO in these further slides. Designed for this study, this is a prospective multi-center randomized control trial. Macquet, an ECMO equipment provider, provided the cannula circuit device but were not involved in the trial design, data analysis and interpretation of manuscript. Research staff members responsible for the primary outcome were blinded, while the participant medical and nursing staff were not blinded. Randomization was stratified according to center and the duration of ventilation before the randomization, less than 72 hours versus more than 72 hours. Allocation consentment was ensured using the centralized secure web-based randomization system. Healthcare workers had protocol training for prior to trial commencement. Target sample size was 331 based on accepted 60-day mortality rate of 60%, estimated 40% mortality in group. For 80% power at alpha level of 5% with the group sequential analysis occurring after the randomization of every 60 participant. Stopping the rules using the two-sided triangular design methodology were defined prior to the commencement of the trial. The trial could not be stopped due to the safety due to excess mortality in ECMO arm. Efficacy: mortality is unlikely to reach a definitive result. The Data Safety Monitoring Board (DSB) recommended stopping the trial after the fourth interim analysis 249 by 33 331 75% planned recruitment, where it made the predefined stopping the rules for mortality. Post-hack rank preserving the structural failure time analysis was performed. Adjust for high rates of crossover in control group in estimation of survival. Setting for the study: this is setting 64 centers international through the predominantly in France. Non-ECMO centers were included if they had extensive expertise in treating patients with ARDS and ECMO could not be established within 2 hours of randomization. ECMO centers were not defined. Inclusion criteria: ARDS, American European Consensus Conference definition 1994, endotracheal intubation less than 7 days, and had one of the following disease severity criteria despite the optimization of mechanical ventilation: FI2 more than 80, tidal volume 6 ml per kg, predicted body weight, and positive and expiratory pressure PEEP more than 10 cm of water. Despite the potential use of various usual adjuvant therapy, inhaled nitric oxide, recruitment maneuver, prone position, high frequency oscillation, HFO, ventilation, almetrine infusion, PaO to FI2 ratio less than 50 mmHg for 3 hours, more than 3 hours, PaO-FI2 ratio less than 80 mmHg for 6 hours, or arterial blood pH less than 7.2 with a partial pressure of arterial carbon dioxide PSO2 more than 60 for 6 hours with respiratory rate increased to 35 per minute, resulting from the mechanical ventilation setting adjusted to keep a plateau pressure less than 32 cm of water. First tidal volume reduction 1 ml per kg decrement to 4 ml per kg. Then PEEP reduction to the minimum 8 cm of stool. Exclusion criteria: this is a 18 less than 18 years old, excluded mechanical ventilation more than 7 days, pregnancy, overweight, weight more than 1 kg per centimeter, height of BMI or BMI more than 45, long-term chronic respiratory insufficiency treated with oxygen therapy or non-invasive ventilation, cardiac failure resulting in a veno-arterial ECMO, history of heparin-induced thrombocytopenia, cancer with life expectancy less than 5 years, moribund condition for simplified acute physiology score, SAPS value more than 90, current non-drug induced coma after the cardiac arrest, irreversible neurological injury, decision to withhold or withdraw life-sustaining therapies, and expected difficulty in obtaining vascular access ECMO in a femoral or jugular vein, or situation in which the ECMO device is not immediately available. 1015 patients were assessed for eligibility. 249 patients were randomized. Mean age range 50 to 54. Mean SOPA score C1 10.6 into 10.8. Mean EF ratio range was 72 to 73. Septic shock range 65 to 67. Bacterial pneumonia was commonest diagnosis followed by viral pneumonia. Recruitment maneuver were more common in control group 34 by 125, 27 and 22 125. Otherwise, there was no obvious difference in baseline characteristics between the baseline groups. Intervention: veno-venous ECMO, percutaneous cannulas with the access of cannula inserted in the femoral vein. Return the cannula inserted into SVC via the jugular vein. Macute cardio-HEP TM device and Macute HLS set advanced 7.0 TM ECMO circuit. The pump flow outflow fraction of oxygen delivered FDO2 by the gas blender annex and air oxygen mixture were adjusted to obtain PO2 between 65 to 90 or arterial oxygen saturation more than 90. The membrane ventilation was adjusted to maintain partial carbon dioxide PCO2 less than 45 mmHg. Ventilator setting during ECMO: volume assisted control mechanical ventilation mode of the following setting: FI to 30 to 50, PEEP at least 10 to 10 cm of water. Tidal volume was lowered to obtain a plateau pressure 25 to 24 cm of S2 or less, respiratory rate 10 to 30 breaths per minute, or bilevel positive airway pressure release ventilation APRV with the following setting: FI to 30 to 35, 30 to 50, PEEP at least 10 cm water, high pressure level 24 cm of S2 or less, respiratory rate 10 to 30, anticoagulation with heparin targeting APTT 40 to 55 or anti 10 0.2 to 0.3 international unit. Control: volume assisted control ventilation FI to 0.21 to 1, adjusted to obtain the saturation SaO2 between the 88 to 95 or PO2 55 to 80. Tidal volume set 6 ml per kg predicted body weight. PEEP set not as it exceeded the blood pressure 28 to 30. Neuromuscular blocking agent and prone position were strongly encouraged for control group patient. With oxygenation objective were not met during at least 1 hour. Despite an FI to at least 0.8, the following adjunct therapies could be used at the discretion of treating clinician. Recruitment maneuver: inhaled nitric oxide or inhaled prostacyclin or intravenous almatrine. The RR2 could be set up to 35 breaths per minute and adapted so as to obtain arterial pH between 7.30 to 7.45. If despite respiratory rate 35 breaths per minute, the pH remained less than 7.30, sodium bicarbonate could be infused. If the pH remained less than 7.15 with a PCO2 more than 35, and tidal volume could be increased stepwise 1 ml per kg up to 8 ml per kg to obtain pH at least 7.15, provided that the PCO2 remained at 35 mmHg or higher and the P plateau pressure remained less than 32 centimeter of water if necessary to decrease the PEEP to 5 centimeter of water. If despite tidal volume set to 6 ml per kg, plateau was 30 and PEEP could not be lower by 5. If despite the tidal volume set to 6 ml per kg, PEEP set 5 centimeter of water, the plateau remains among the 32 centimeter of water. Tidal volume could be decreased stepwise 1 ml per kg down to 4 ml per kg, provided that the pH was maintained at 7.12 or above. Cross over the criteria from the control to ECMO. SaO2 saturation less than 80 for 6 hours despite the use of recruitment manure or inhaled nitric oxide, inhaled prostacyclin, or test of a prone position. If the physician in charge of patient believe that this could be actually change in the outcome. Patient care at a non-ECMO center, the mobile ECMO retrieval team was alert if the aforementioned criteria were met and team initiated the ECMO at the non-ECMO center, returning to their home center with the patient that receiving the ECMO. Management common to both groups: administration of corticosteroid, choice of sedation, analgesia, hemodynamic management, weaning from the ventilator, and tracheostomy were left to the discretion of the treating physician. Outcome: primary outcome, no statistical difference in mortality day at a 60. ECMO group 44 by 124, 35% versus control group 57 by 125, 46%. Relative risk 0.76. Secondary outcome: compared to the control group, ECMO group had a lower relative risk of treatment failure. Treatment failure was defined by the death by day 60 in patient with ECMO group and crossover to ECMO or death in patient in control group. Lower risk of renal replacement therapy at a day 60, 50 versus 32, median difference. Underweight less pruning, 59 versus 46. Crossover to ECMO occur in 35 by 125 control patient, occur to median 14 days, median to PO2 ratio 51. 9 patients had cardiac arrest, 7 had a right heart failure, 11 received RRT, 7 underwent the veno-arterial ECMO. 60-day mortality was higher in crossover the patient than a rest control. In crossover the patient was versus 90, remaining the crossover the patient. The hazard ratio for death within 60 days for the ECMO group compared to the control subject the adjusting the selective crossover. Adverse events compared to the control patient, ECMO patient had a more severe thrombocytopenia, more bleeding events, less ischemic stroke. Strength for this trial: important to relevant research question about the effectiveness of ECMO in severe AIDS. Largest multi-center ECMO RCT to date. We require our largest multi-center. Standardized criteria for entry into the trial for the initiation of rescue ECMO. Almost all patients with randomized the receive, unlike the concealment. Protocolized delivery of ECMO mechanical ventilation result in standardized treatment in both intervention and control groups. Witnesses underpowered to answer trial question. Trial was stopped early at a 249 patient due to the redefined fertility rules, unlikely to get definite result, leading to high risk of study was underpowered. Role of interpretation stopping the rules of major RCT is controversial. Implausible power calculation. Initial power calculation based on the 60% mortality in mortality group control group, which become clear was implemented compared to the actual mortality controls to 46. Lack of blinding of clinician patient families, slow recruitment up to 49 patient over the 6 hours, threats to external validity, expertise ECMO center not clearly defined, importance of VV ECMO configuration uncertain, Majority of AIDS patients with trial were made had pneumonia and septic shock. Extrapolation other AIDS patient groups uncertain. The trial does not distinguish between the use of VV ECMO and VA ECMO. In particular, 7 crossover the control patient VA ECMO cardiac arrest. Some inclusion criteria have been to be liberal, which may dilute the benefit of VV ECMO. Expose the patient who might may otherwise live in a complication of ECMO. Author conclusion: the ECMO for severe AIDS showed no significant benefit of mortality day 60 as compared with the strategy of conventional mechanical ventilation, which includes the crossover the ECMO. Use of 28 of the patient in control group. The EOLIA trial provides inclusive support for the benefit of ECMO in severe AIDS. The early initiation of ECMO did not improve 60-day mortality with absolute risk reduction 20 compared to standard care inpatient. However, the data also suggests that possible clinical benefit from ECMO over the standard care, especially used early rather than late. Standard therapy, including proning or neuromuscular blocking, had higher rate of failure requiring rescue with ECMO.